morning, everyone. Today I'm going to discuss with you some tips about the brain infarction. I won't be classic in the presentation in terms of describing the etiology and then pathophysiology, the imaging features of the infarction. And instead of this, I present some cases or some case scenarios, and then through the discussion of these cases, we will come out with some tips about the brain infarction. So let's start with the first case. I think it's very easy and very basic. So if you presented with a patient who had some neurological symptoms, and then according to the stroke protocol, you started with a non-contrast CT examination just to rule out that this is an infarction or hemorrhage. And I think the abnormality is very obvious in this case. So this case presented, for example, with right-sided hemiplegia. The abnormality on the left side is very obvious. So can anybody describe this? Just a description? Nobody? So you have like hypodensity here in the left frontotemporal region with some effacement of the cell side, some edema, and mass effect. There is no evidence of hemorrhage, right? What's your likely diagnosis in this case is infarction. Yes. Okay, so if I present another image for the same patient showing pathology in the same area, anybody can describe this one? Now we have hypodensity also at the same region, but with CSF-like density. So what's the difference between this image and this image? Yes, it's the time. So this is a recent infarction, while this is a chronic infarction. And accordingly, if I present another image for the same patient, just few hours after the presentation of the symptoms, the presentation with the symptoms. So it's hard to detect the abnormality here. You may say that there's some effacement of the cell side, or could be a normal study, but still this is after the presentation of the patient to the clinician. Another image of the same patient, again, you will have hypodensity at the same area, but with different level. So here's the first step, that infarction is a dynamic process. That means that the imaging feature of the infarction will differ according to the time of acquisition of the image in relation to the presentation of the patient, right? So if we want to arrange all these pictures in a chronological manner, so we'll start with this one, in which you hardly appreciate the presence of the infarction, and this is the hyperacute stage. And then the acute one, where you can see the hypodensity and settled infarction. Then the subacute one with diffuse hypodensity and effacement of the cell side. And then lastly, the chronic one with encephalomalacia and gliosis and CSF-like density here with negative mass effect. So the first step that I said that the CT findings in infarction change over time. So you won't expect to see the same imaging feature in each patient even in the same patient at the same time. Okay, if you just image the patient a few hours after the infarction and then more further hours and then days and then weeks, then you will see some changes. And these changes related to the healing process of the infarction. And it's not related only to the healing effect. It may be related also to the complication. So if I show you an image like this is another patient with infarction on the right side, and this is just few hours from this image. We image the patient again, and we have this abnormality. What kind of abnormality here? Yeah, hemorrhage. So this is hemorrhagic transformation. So it's not only related to the healing, but it's also maybe related to the complications of the infarction, like hemorrhagic transformation. So as I said, the ischemic stroke can be divided into hyperacute, and this is in the first 6 hours, acute 6 hours to 48 hours, subacute from 48 hours to weeks, and then chronic weeks to months. Okay, the second case scenario. I present again the same patient who presented with right side hemiplegia. Okay, and then you did this CT, and you find that there is like an infarction in this area. And the technician came to you and asked you, would you like to inject a contrast in this patient? renal function is okay, and the IV line is there. So would you like to inject the contrast or not? So how many of you will agree to inject the contrast in this patient? Just raise your hand if you agree. If you agree, just raise your hand. Nobody agrees? Whatever, we will discuss this, but you agree to have a contrast? You agree to have a contrast from the start? No. Who said yes? Nobody? Okay.
If you want to do the angiography for hemolytic therapy, you can do a contrast.
Okay.
Otherwise, if there's no indication, why to do contrast?
Okay, that's fine. I'm not discussing here the right and wrong practice. I'm just trying to know what's your options in such case and what's the causes behind this. Anyway, this patient was injected with a contrast, and we saw this pattern of enhancement. Which kind of enhancement pattern you are seeing here? It's a? It's cortical or gyral pattern of enhancement. Okay? And this is one of the most classic appearance of the post-contrast enhancement of the infarction. The gyral pattern. There are many options or many other appearance of contrast enhancement in cases of infarction, but this is the most classic one. Why this enhancement is there in cases of infarction? As we said in my last lecture, that due to disruption of blood-brain barrier, so you will expect some contrast to leak from the intravascular space into the extravascular space, so you will expect to see some enhancement. In addition, the brain or the body try to compensate the reduction of blood supply to the infarcted area through meningeal and cortical vessels. And that's why you will the result will be like the gyral pattern of enhancement in cases of infarction. And similarly, you can see this in MRI also. Look, this is a very thick gyral pattern of enhancement. This is another image. This is the gain MRI. This is the pre-contrast T1. There's T1 hyperintensity in the pre-contrast, which may represent some hemorrhagic changes. And then this is the post-contrast. Look to the avid gyral pattern of contrast enhancement. This is again another case with very thin, uniform gyral pattern of enhancement in a case of infarction. Okay, so 90% of the infarction will show this pattern, gyral enhancement, after 1 week. 90% of the infarction will show this pattern of enhancement. On the other hand, 35% only will enhance by the 3rd day after the onset of the symptom. So in the chronic phase, you won't expect to see enhancement in the post-contrast study. And also similarly, in the acute and hyperacute stage, you won't expect to see much more enhancement. You may be presented with some patchy enhancement in the substance of the infarcted area, but the characteristic gyral pattern of enhancement, you will see it in the subacute stage only. Okay? So the images I showed, this was like Dr. Dia asked first, that this is a delayed phase. But we can use contrast in another way. So let's just revise the protocol of ischemia or stroke. So the first question you will ask yourself, is this a stroke or ischemia? And ischemia or hemorrhage? And you can answer this with just non-contrast study. The second question, is there a flow obstruction or not? And then you have to do CT angio to answer this question. And then if the infarcted area is serviceable or not, you have to do CT perfusion. Okay? So this is the same patient again. This is a pre-contrast, while you see hyperdense vessel sign at the left MCA segment 1, and then in the angio you see the occluded vessel. Okay? So this is a different way to use the contrast. You may use it in arterial phase, like in this phase, and it's useful actually to define the etiology and the cause of the infarction. And this also helps the intervention people to decide just to go and intervene with this patient or not. And the delayed phase would show the classic enhancement. But actually, you said that the delayed phase showed that classic gyral pattern of enhancement didn't add anything to your diagnosis. So you want to change your diagnosis from infarction to cerebritis, for example, based on this contrast enhancement. This is another pattern of enhancement, thick gyral pattern with some edema. Again, gyral pattern of enhancement. More pictures. This is infarction and then left MCA infarction with gyral pattern of enhancement also. Okay, so the contrast is useful, right? In terms of angio. Maybe it's not useful as you said from the start, in the delayed phase. Okay, so let's move to third case scenario. Okay, just listen carefully to the history of this patient. This patient presented with neurological symptom like right-sided hemiplegia, okay, and presented to a hospital few days back, and they did CT for this patient and said, okay, you might have an infarction. The patient at that time refused to have treatment and just went home. As the symptom persists, the right hemiplegia, he came to your hospital, and then the neurologist asked for a CT to rule out infarction. So you did non-contrast CT for this patient. So can anybody see any abnormality in this CT scan or not? Grossly. Here, on this side? This one, the left side. You may agree, you may not, right? Okay. Okay, I may agree, I may not. But still, it's not conclusive. So, what's the cause of the symptom of the patient? The patient presented few days back with these symptoms. So, why this appearance is likely normal? And how we can solve this? So, what's your suggestion? What to do for this patient? I mean, to do here, you may say that there's abnormality and make the other radiologist will say no, there is no abnormality, it's likely a normal study. So how to solve this? The patient is complaining. This is a suggestion, just to do MRI. And you may search for something like diffusion weighted image as a rapid scan, just have it, and if the patient has an area of diffusion restriction, so this is most likely an infarction, right? The patient did diffusion weighted image, this is the ADC map, it's completely normal.
Migraine, sometimes the patient with migraine can present with symptoms.
Sorry?
Migraine. Some patients with migraine can present with symptoms.
Yeah, but this patient presented with right side hemiplegia, and already he did a CT scan elsewhere, and they said you have an infarction. So why the infarction is not there if there's really an infarction?
Vascular response.
Okay, but again, you have to see something in the brain because the patient is still complaining and symptoms are progressing. Okay, CT angio, maybe it's helpful. Anyway, this patient did a delayed post-contrast study. Okay, before the delay, this is the previous study of the patient, and already you can see there's an abnormality here, and it's most likely an infarction, right? So why it's not there in the second scan? Okay. So the patient did a post-contrast study. This is an MRI. So what's this button of enhancement? The gyral button, which is classic for the subacute stage of an infarction. So, and also in the flare weighted images, you can appreciate also these abnormalities, and it's not always there. Maybe you will see it in the post-contrast study only. So what you see in this case is called fogging effect. Okay. Fogging effect was first identified in 1979, and this fogging effect, as you see, masked the late diagnosis of stroke. And surprisingly, the fogging effect is there in 54% of all skin stroke. So if you image 100 patients with a stroke, in 54 patients you will see this fogging effect. Okay, so in this fogging effect, you didn't see the hypodense or the usual hypodense appearance of the infarction. Right? Why is this? So before going to describe the fogging effect, I want to discuss with you the cause of hypodense appearance of the infarction. Why the infarction appears as hypodense area in brain. Okay? You know that in ischemia, there is like a cut of the blood supply to an area in the brain, right? And secondly, to the blood reduction, the consumption, the need of oxygen is not matched. I mean, the tissue doesn't get any oxygen, the needed oxygen for metabolism, right? Then this will affect the sodium-potassium bond, lead to swelling of the cells with water. And as the water content increases in an infarcted area, the Hounsfield unit will decrease 2.5 Hounsfield for each 1% of increased water content on the tissue. So the first cause that you see the infarction as a hypodense area is due to the water content and edema. right? With time, the body try to just remove the water in the healing process of the infarction, and then you will find some laminar necrosis, some area of hemorrhage. The macrophages just come to this area just to clean the infarcted area. This process leading to increased density at the infarction area. So at that time, you will see that the hypodensity reverses to isodense density, and then it masks the normal appearance of the infarction. So again, let's see this case. So this case presented with an infarction in the left basal ganglia with a hypodense area here, seen obviously in the acute stage. Okay, so the hypodensity, again, I said due to the water content of this tissue because it's increased. With time, the body tries to remove this edema and remove this water, and some macrophages will come and fill this area just to clean the dead tissue. In addition, some microhemorrhage may occur also in the substance of the infarction area, and that's why you may, after a few days, you will see it like this. This doesn't mean that the infarction has gone or vanished. This is just the in the processing or the healing process, some changes will happen result in disappearance, and this is called fogging effect. So again, I said the fogging effect occurs in 54% of ischemia or infarction patient, and if you see a positive fogging effect, this is associated with a good prognosis. Okay, and what's the solution if you face something like this? You have to inject contrast, because the fogging effect occurred just few days or few weeks after the presentation of the patient. So you will see the infarction area as a normal area, and this is the subacute stage. And before this case, I show you that in subacute stage, the infarction will show gyral pattern of enhancement. So your solution at this stage, you will just inject the contrast and have a delayed phase this time to see the classic appearance of gyral pattern of enhancement. Okay?
Still patient bleeding at the time.
Yes, yes. And of course, if you see the previous images, you can identify the area of infarction very easily. Okay. So again, this is another example of fogging effect. This patient presented with bilateral occipital infarction, and just a few days after this, it seems like to be a normal scan. But still, the infarction is stable. This is not a vanishing infarction. So again, this is a non-contrastive study for a patient of infarction with hyperdense vessel sign. In the acute stage, you will see some edema and some effacement of the cortical subsidus or periortic differentiation. Few days again, you may say this is the fogging effect. Again, it's preserved due to laminar necrosis in this area and just the presence of macrophages, resolution of the edema. So again, you will see like a normal study. And if you inject contrast at this stage, you will see the characteristic pattern of gyral enhancement of the subacute infarction. Okay? So now the contrast is useful in cases of infarction if you face such a situation. But if the infarction is there, so you won't need a delayed post-contrast study. You may use the angio stage. Okay? And interestingly, fogging effect can be seen also in the MRI. And this is beyond my discussion now. Maybe I'll present it in another picture. But it can be in the CT and also it can be in the MRI. And the solution in both cases to have a contrast study. In conclusion, to this fogging effect, the cerebral infarction can be neglected or severely underestimated based on non-contrast scan performed during the second and third weeks after ischemic stroke, which is the subacute stage. Contrast-enhanced study should be performed in the subacute stage of ischemic stroke to avoid diagnostic errors related to the fogging effect phenomenon. Again, this is another example. This is an infarction in the acute or hyperacute stage where you hardly detect the infarction area, then the acute stage, then subacute stage where you see the fogging effect. You cannot demarcate the infarction in this area, and the post-contrast is the solution. I think there's no time for the fourth case, but I just rapidly go through it. Sometimes, and this, the infarction, especially the posterior fossa, like in the cerebellum here, this is an area of infarction, and it's proved that this is an infarction. But look to the contrast enhancement. It's not always like the gyral pattern, so contrast can be tricky sometimes in infarction case, so you may misdiagnose this as a tumor, and this is called pseudotumor sign. And it's firstly described in cases of infarction, cerebellar infarction, and not cerebral infarction. But it can happen also in the brains or ventricle. This is another example. This may resemble like gyral pattern of enhancement. This is another case. This is very interesting. You see like a solid enhancement. This is proved to be an infarction also. So be careful that contrast enhancement in infarction sometimes can be tricky. It's not always classic. To conclude, ischemic stroke, as I said, is a dynamic process, so you will expect some changes with CT over time. It's not always the same image. Gyriform enhancement occur in 90% of the subacute infarction. This is the only phase you expect to see an enhancement in the infarction. Fogging effect can mask the diagnosis of late stroke, and post-contrast is the solution in these cases. Infarction enhancement can mimic tumors in some cases, so don't be tricked with the enhancement. Okay? Thank you so much. Any questions?